Good morning, everybody. How are you guys? So I was given this topic to be followed, to follow the glaucoma and papilledema. I've been told now that I need to talk first. So there might be a few references which I know are in their talks, but we'll go with it. Please don't hesitate to ask if there's something that is missing, because the whole idea here is practical approach to the patient. That's what the session is about. So I would rather do 5 slides and help one of you to take 1 point home so that you can do practically, you can apply it to the patient rather than me going through the presentation. So the topic I was given was deceptive disc, looking at the bigger picture. A bit difficult to decipher, but because it is deceptive, so let's start with the deceptive bit of it. I'm practicing presently in UK, so my talk might have a few of history bits in it, but of course too much of science can be boring also. I still feel that clinical skills are probably the most important despite all the technology. Digvijay might, being the younger ophthalmologist, might talk of AI and all these technologies, but they can only be as good as the person who is looking at the visual fields, looking at the disc. So it's something where I feel the patient and doctor interaction is a must. There are talks about you don't need to see glaucoma patients, you don't need to see. I probably differ, but I wanted to ask a question to Digvijay in one of his AI sessions, but I never did. It's something like, you want foundation, then you can have a small or a big house, but you want a foundation which is good. Coming back to deceptive disc, what is disc? If I look into the definition of disc, it is a flat, thin, circular object. But my previous speakers were supposed to talk about excavated discs and raised discs, papilledema, and is it glaucoma or neurological? So, well, they've not spoken, so there will be a few things that you have to remember this talk and then put it after their talk. We also think the disc as intervertebral disc, the disc as floppy disc. So it is confusing, it is deceptive, the word disc itself. I'm reminded of this Prof. Harry. He was the pioneer for the disc, and any talk about optic disc without mentioning him, I think, is incomplete. He had articles written about him in IGO when he was alive, and then in American Academy of Ophthalmologists when he passed away. Just a few fun facts. How many of you have done your graduation MBBS from 2 colleges? He had. It was circumstantial. 1946 he started in Lahore, there was partition, and then he moved to Amritsar. Fun facts. He does not have any degree for America, but he worked last 50 years in America. Fun fact, the very first time, he was not even in ophthalmology, he started his research in optic disc and carried on from there. So yes, so he called it optic nerve head, which is what I also like to call, but again, it's just a matter of nomenclature. The next part of deceptive disc, looking at the bigger picture, I just wanted to highlight what all things are we looking. So I've kept the abnormalities aside, and even if first thing is anatomy, then is pathology. So I'm sorry that for some doyens here, it's very, very basic, but then it was supposed to follow after the high-tech talks. So with all these points, which are not really anything to kind of talk about, we have to identify the disc margin first, and after that we need to see where the neural rim is, what we call as cup disc ratio. Yes? Nobody's okay. Good morning, everybody. Somebody wake up, yeah? Okay. So, the technique is very important. Light in the room has to be ambient, thin beam, use the slit lamp for its slit, and focus, if possible, with the dilated pupil. I know people have less and less time, but at least the initial evaluation, and then document. The thing is, we can use lots of techniques. We can use the technology bit, which is disc photos, HRA, SLO, blah, 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 and we can use various lenses. But one thing you have to remember, size does matter. There's a magnification factor, there's a correction factor for each lens. And would you believe it if I told you that 290Ds of two companies have different correction factor? Okay, so when you are checking the size of the disc, at least in the first go, and then you can check the size of the cup on every occasion if you are looking for progression, etc. You need to make sure that you're using either the same lens or you're putting in the correction factor as well. The asymmetry, I don't know which one is normal. Can anybody point to which one is normal? Anybody? Both are normal. The left one, the scleral canal is slightly bigger, and hence the total, we as a convention, we use vertical diameter. So in the left eye, we can see, because the size of the disc is larger, the size of the cup is larger, CD is different, and this patient can be or should be at least followed up to rule out or establish progression. There are various normals. I don't know what is normal, but I call it average, I call it typical. And the appearance will not only be dictated by the scleral canal, it will be dictated by how the nerve comes and attaches itself to the eye. And what I as a clinician want to know is, number one, is it a pathology or not? And number two, is the pathology treatable or not? Because there's no point of, just highlighted by Prof. Tam, that there's a patient who was treated for glaucoma, operated for glaucoma, and then I don't want any of my trainees or any of my patients to go through that. But it happens. Despite everything, this happens. So let's try and hold on to. This is a case which was very close to my heart, because this patient had seen 3 consultants previously. Can you see what is there? It had a visual field defect which was corresponding to the optic disc appearance, and the patient had a family history of glaucoma. But then this is not glaucoma, this is optic disc pit. If you use the technology only and not see the patient, it fits. There's a visual field defect on superior thing, and can you see there's a macular schisis also next to the disc? There is a defect, but this is not glaucoma. We don't need to operate on the patient, do TRABs, and then realize. Again, call me an old school, but that's what it is. The last bit, looking at the bigger picture. There was this study, BEEP, Bridlington Eye Assessment Protocol Program, one of those names, so BEAP. And they looked at about 10,000 plus normal individuals. It was an epidemiology, it was an epidemiological study, it was not patients. And what they found was that normal distribution of the disc size and hence the area was as varied as 1 to 3 square millimeter. Now 1 to 3 square millimeter might not sound very much, but if you look at the percentage, you are talking about 200%. That's a lot of percentage points. And there was some which even came up to 6%, 6 square millimeter. Oops. Okay. So this was supposed to be another histogram for disc asymmetry, where what they did was right side CD ratio minus left side CD ratio, and that was put on the graph, they saw that 85% were within minus 0.2 and plus 0.2. But there were 15% in the 10,000 patient group or individual group who did not have any problem, who did not have any pathology, but they were still outside that. So this asymmetry also. So looking at the bigger picture, we know it's not unusual. So yes, we need to find the pathology and we need to pick up the battles that we can fight.
Yes. Thank you, Dr. Naresh, for for kind of bringing us back to the foundation.
B2B.
B2B, and to look at it as well. I mean, obviously, the thing to realize is that all these classifications of normal, abnormal are something that we have gotten, not that nature has got it in. So it is a continuum or a spectrum that we kind of as humans like to classify in our intelligence, and this is now what we are pushing to the AI.
Well, I mean, yes, AI is very good provided we look at it. Even the simple thing of HRAs, SLOs, the computer decides which layer where, and it projects a red and yellow and green. But unfortunately, I mean, we never, at least most of my colleagues never look at where it has plotted. Oh, it was yellow, it is red, now it is progressive. No, look at, because you need to understand how the machine works, where it is plotting, and how is it giving those, what is that called, false pseudo colors.
Right.
But then, yeah, I mean, I might be old school, but I'll be learning from you, Digvij.
And I think coming to colors itself, I think as you discussed, that itself can be deceptive in terms of the real natural colors. What may appear pale to one may not be pale at all.
No, for example, Heidelberg, it gives pseudo colors.
Yeah, those are, of course, it's putting them on.